We're very pleased to have with us today Dr. Philip McCarthy from the Roswell Park Cancer Institute, and he has obviously been very active in myeloma research for many years and has a particular interest in the role of transplant and actually the role of maintenance after transplant as well. And so we're very pleased that he's able to be with us here today and take us through this aspect of myeloma therapy. So please welcome Dr. McCarthy.
Thank you, Dr. Berry, for that nice introduction. I initially thought this was 30 minutes, so I had too many slides. So I had to cut some, and my book has way too, or what's in the book is too many, so you have extra if you want to read about it. These are my disclosures. Mostly I have consultation for a variety of companies that are involved with either diagnostics or the treatment of myeloma. So I bring this up. This is a variation of the skipper hypothesis, it's fractional cell kill. And it points out how hard our job is because the diagnosis of most cancers occur when there's over 1 billion cells. So 1 billion cells, if you push them all together into one lump, is about the size of a sugar cube. So that points out how hard it is sometimes to detect a disease, especially like myeloma, which is a diffuse disease. It's everywhere. So you can be at the level of detection and have just under 1 billion cells in the body that we can't see right now using our current techniques. So we try and kill something off so that it goes away completely. But even if you knock off 90% of something, 90% of 1 billion is what, 100 million. So we still face this issue. Sometimes with surgery, if something is localized, it can be removed and then further treatment. And for patients who don't respond, the disease gets worse into the trillions. So this is in the time, we can have up to 1 trillion cells in the body at the time of diagnosis. So this is important because it means that we have a lot of cells that have to be eradicated. So I'm going to start with just some questions. Is there a best induction? Stay tuned. I'll show you some data on that. Should patient receive fixed duration versus until progression therapy? What's the role of high-dose melphalan in transplant? What are the best therapies after transplant? And will agents that are being used for relapse refractory disease now be incorporated up into induction therapy? And I'll say yes, but those are being tested. So I'm going to give you some terms because we often sometimes show graphs. Progression-free survival is the length of time during and after treatment of a disease that the patient lives without the disease getting worse. Measuring PFS is one way to tell us how well something works. Overall survival is the length of time either from the date of diagnosis or the initiation of therapy the patients are alive. In a clinical trial, measuring the OS is another way of measuring a response. Obviously, OS is the most important, but PFS is also important because that usually means the patient needs more therapy because their disease has gotten worse again. And so then lastly, I'll talk about hazard ratios. So I'm not going to go in great detail, but what it tells you is the risk of something. So a hazard ratio of 2 is if you have something where the disease progression is twice the rate as the control, the hazard ratio of 2 is 2, indicating a higher hazard of progression. If you have something that occurs 10 times more frequently in men than women, the hazard ratio is 10. And there's some things called forest plots, which are in the book. And again, it's just useful for understanding. I'm not a statistician, and I don't attempt to even pretend to be one, but it's useful for understanding some of these graphs that we put up. So what is the Kaplan-Meier analysis? This is to estimate a population's disease progression or survival. If all patients are followed until progression or death, the curve is estimated by calculating the fraction of patients surviving over time. However, patients drop out. They can move away, they decline further therapy, they have an adverse event, or they get lost to follow-up. So this Kaplan-Meier is 2 statisticians who came up with a way of trying to account for that when you try and examine a clinical trial. So this is also what happens. Not everybody starts on the same day of therapy. So what you do is here are patients who have started at various different times after the diagnosis, and then some have come off because they've had disease progression or they've come off from an adverse event. So what a Kaplan-Meier curve does is it lines everybody up as if they're all starting on the same day. Okay, that's why you see those survival curves, and this is what this does. It accounts for that in this way. And then what happens, this is a very simplified version. There's the website if you want to go look at it. But there are patients who may come off because they're censored. Here are two that are censored, these little lines. And then we have a patient who may have a progression. And then we have another who's censored, and then another progression. So this gives you the estimated survival, accounting for the fact that people would not have progressed, but they're no longer being followed on the study. It's complicated, but it also gives you an idea of how we have to factor all these things when we look at our patients' progression-free and overall survival. Because if somebody is taken off for adverse events, and we have a whole bunch of patients coming off for adverse events, that may not affect the progression-free survival, but it means how tolerated is the drug. And this is, again, now to show you a Kaplan-Meier curve. This is the survival now from 2001 to 2010. You can see that in the 70s, 80s, we didn't have a lot of advances, but now with the new drugs, we're beginning to see increased survival. I'll show you some others, and I had a slide which is in your book, but I left it out, showing that up to 2014, we're now seeing even better survival. So I got this. This is the ending is already in the book. Before the new drugs, treating myeloma was like waiting for the taxi. None would come. And all of a sudden, 5 taxis show up at once. And now we have this great problem of having multiple drugs and trying to figure out which one to use or which combination to use. And this is a variation of what Dr. Abenour talked about. You assess how fit the patient is. Are you going to do a 2 or 3 drug? We're now moving more to a 3-drug combo. And the most important thing is exposure to drug. If you give a 3-drug combo and the patient's having trouble getting all 3 drugs and you have to stop it, then you're not exposing the patient to drugs. And so that's important too. They have to be able to tolerate the therapy. And then now with fit patients or patients who are transplant eligible, transplant's an option. You could potentially store the cells. I do recommend doing that if you're not going to have transplant up front. And then at progression, there's a variety of different options, which will be talked about later. So this is just for transplant eligible. Patients are given a transplant after induction therapy, and then there's some questions as to fixed time versus, or if not in CR versus until progressive disease. And then the supportive care is incredibly important for antivirals, DVT prophylaxis if on an IMiD, bisphosphonates for skeletal-related events, and mitigation of all the toxic effects of steroids. In Europe, consolidation is more common. We don't do it as much in the States, but we do for certain high-risk patients. And then maintenance until progression is at least the gold standard for most patients. Now, there's a whole bunch of these, and this is just to show the timeline. Back in the 70s and 80s, we didn't have a lot. Oral melphalan was one of the first drugs. And then the IMiDs were the first big advance, thalidomide, and then lenalidomide, now POM. And then they're now called CellMods. It's a new patenting opportunity for Celgene. And I'll talk about those briefly. These are the proteasome inhibitors. These are the 3 now, bortezomib, carfilzomib, and ICSA. These are in clinical trial. And then the HDAC inhibitors, panavinistat has a label. There's others that are being tested now for efficacy. Then the monoclonals, ELO with Lendex, daratumumab, usually in combination. There's a variety of that are being tested. Pembro turned out to be too toxic. I don't have a slide for that, but that's why you do a trial. It turns out when you add pembrolizumab, a checkpoint inhibitor, Lendex, compared to Lendex, it was worse, both in terms of overall survival and progression-free wasn't that much different. So this is why you do a study. So these trials are all on hold now using checkpoint inhibition. We'll have to see whether or not it'll be resurrected, but again, this is why we do studies. There's isatuximab, which is a variation of daratumumab. There's a variety of other targets. And then these are all ongoing clinical trials, mostly in relapse refractory, which you'll hear about later on. So that's a good thing. We have lots of potential targets for a disease that currently is not curable for most patients, and thus there's an interest, obviously, in the holy grail of curing this disease. So this is, I'll go through quickly, this is called the proteasome in degradation of ubiquitylated proteins. And this is essentially housekeeping. So proteins are ubiquitylated in the cell, they come along to the proteasome, and then they're degraded. And this is what normally happens in your body. It's degradation of proteins, recycling, and keeps the cell fit. What Velcade or bortezomib does, or the proteasomes in general, is they block this degradation. So for the myeloma, it's very toxic, and the myeloma cells have a backup of all those proteins, and they die, and the plasma cell dies because of this backup. Now, this is how IMiDs work. They bind something called cereblon, and also do the cell mods, which are derivative. They bind a variety of factors which are involved also with ubiquitination, and then transcription factors. And these transcription factors turn on or off the cell machinery in the DNA. In myelodysplastic syndrome, lenalidomide works for that. If you have 5q minus, there's a general anti-tumor effect when this transcription factor is bound. And then this is something called Icaros. There's Icaros, Alios, there's a bunch of them. They're all discovered by a Greek investigator who named them all after Greek things. And this is what works in myeloma, thalidomide, len, pomalidomide, and now these new cell mods which are being tested. As you can see, they're also being tested in a variety of other diseases. This is going to be out in something called Understanding the Pathway. It hasn't been published yet, and you can look at that figure. So this is probably the most important slide with regards to induction. This shows you where we were and where we are now. So I'm not going to go over in great detail, but to show you in the old days, when VAD stood for vincristine, adriamycin, dexamethasone, you can see the overall response rate here in the sort of salmon was less than 60%. That's PR, partial response or greater. The yellow is VGPR or greater, and this is the CR, it's very low. And this is with thalidomide added to it, it went up. And then we went to doublets, which are Thal-Dex, bortezomib dex, lenalidomide dex. And here with the lower dose dex, as was mentioned earlier. And now we see with the 3 drugs, we now are beginning to see much higher CR rates. Now this is comparison between Velcade or bortezomib thalidomide dex and bortezomib cyclophosphamide dex. This is a French study I'll show you in a sec. The overall response rate is higher, as is the VGPR or greater is higher. This is indirect comparison. This is Dr. Dury's study. And this is 8 cycles of RVD, and this is 8 cycles of RVD in the French study. You can see it's higher, but it's not the same patient population. So it's hard to make a good comparison because you're not supposed to compare between trials, but I did anyways. But it also points out that you have to be careful when you do compare them. Here's why. This is KRD versus KCD. This is from an Italian study. I'll show you a little bit later. You can see the overall response rate's higher, VGPR greater, CR rate. But this is after 4 cycles of KRD, because when you look at it, you say, oh, they're not that different. So you have to look carefully at the trials when you read them, because when people make comparisons, you have to make sure you're comparing apples and apples. And as was mentioned earlier, this is with cyclophosphamide added to RVD. It was worse. Why? Because people couldn't get the drug as much, so or the whole regimen. So sometimes that 4th drug may not be better. That's why we need to study it. And this is using ICSA, which also generates high rates when you substitute it for bortezomib. This is VTD is superior to VCD. And this is just bottom line. The VGPR rate is higher with VTD over VCD. We don't use this as much in the States. It's more common in Europe. This is the Italian study looking at KCD versus KRD. And here's those 4 cycles. You can see after 4 cycles, the KRD with the carfilzomib-containing one has a higher VGPR or greater and a higher overall response rate. And this in particular, and a higher CR rate when compared to cyclophosphamide. So this is Dr. Dury's trial. This is the VCD versus RD, which was shown earlier. And this is just showing that the triplet is superior to the doublet, both in progression-free survival and overall survival in those Kaplan-Meier curves. This is I'll go through this quickly. You can look through it if you want. These are some old studies showing with older regimens that transplant generated better progression-free or event-free survival and overall survival when compared to chemotherapy alone. This is French, this is English. This is more recent studies incorporating novel agents. This is Dr. Palumbo's study from Italy, same thing. This is Dr. Gay showing the same thing. And then this is again the update from France. I'll show you those slides, which show improved PFS. Overall survival is not done, is not back yet, or it's not mature enough. And this is from the Italian group, again comparing chemotherapy, improved PFS. I'll show you again. This is the French portion of the study. It's done both, some of you may have been on this study. It was done both in France and in the US, chemo, Cy mobilization. We oftentimes don't do this now, but it was done to harmonize the study. Transplant versus continued therapy. And then in France, LEN for a year, maintenance in the US until progression. And so this is the French portion in which showed there's about a 14-month benefit to transplant in terms of PFS. There's no difference in overall survival, but the study's not yet mature. This is the EMN02 trial, and this is a CyBorD or VCD induction. We wouldn't do this nowadays. It was done several years ago. And then chemotherapy with bortezomib, melphalan, low dose, and prednisone versus 1 or 2 transplants, a consolidation or no consolidation, then everybody got maintenance. And again, I'm just doing the bottom line. The progression-free survival is superior for those who got a transplant versus chemotherapy. And then the overall survival rate is not yet mature. This is the Stamina trial. Again, some of you may have been on this. This was a transplant trial where you got a single transplant, LEN maintenance, a single followed by consolidation therapy to improve response, or a second transplant, all followed by LEN maintenance. And then this is the progression-free survival. There's essentially no difference. So we don't know if this is going to stay or if this is going to change over time. And this is the overall survival quite good. You can see that patients are living, the median survival in this is going to be approaching 10 years, which is great. We want it to be flat, but we're not quite there yet. The thing that's interesting about this trial is almost 60% of patients got RVD, and only a smaller number of patients got VCD. So again, when you try and compare trials, you have to factor this in. This is a meta-analysis that we published last year. This is taking the French, Italian, and US trials that all you looked at lenalidomide maintenance. We can see the 7-year overall survival was 62% for maintenance versus 50%, and there is an estimated, it's over 10-year median survival with the use of lenalidomide maintenance. So there is a second cancer risk. This shows the risk of what patients would die of depending on what arm they were on. This is the risk of dying of multiple myeloma if you were on placebo or no maintenance. This is if you were still on LEN maintenance or some patients who had progression and death. And this is the risk of second primary malignancies. It's higher for the LEN maintenance, but it's outweighed by the benefit, the difference here between the placebo and the LEN in terms of preventing the myeloma from coming back. It's a complicated British study, myeloma 11. It's a cyclophosphamide thalidomide dex versus a cyclophosphamide rev dex, and this is here they added carfilzomib. And then if you didn't respond enough, they gave you VCD, and then you got a transplant, and then you got maintenance versus no maintenance. They dropped the varinostat LEN arm. This just shows that CRD is better than CTD. We don't use this regimen as much in the States. We think that bortezomib is far superior to cyclophosphamide, but it just shows that the responses both before transplant and then after transplant were better in the CRD arm. And this shows also the PFS and OS is superior for CRD in blue over CTD. But again, we don't use this, but it gives you an example of the types of trials that are being done to test regimens. This is the LEN maintenance portion of it, and this compares this to the French study. This is a forest plot. If you're on this side, that means LEN maintenance is better, and if you're on that side, it means it's worse. And these are all the hazard ratios showing that LEN maintenance improved. There's a 9% benefit here, 44%, 38%. In other words, that hazard ratio is reflected in the forest plot here, and it's called the forest plot because it sort of looks like a tree. And now they've added here's the myeloma 11 trial, and this is the overall. And this is also showing that in their study, standard risk cytogenetics benefited from Len, high-risk cytogenetics did as well, and ultra-high risk. This meant that the patients had multiple copies of these high-risk features. You want me to stop? I will then stop with what's on the horizon. I can save that for Q&A, and thank you very much for listening.